Alright guys, so we'll start the next topic, that is renal pathology. First of all, as usual, I will talk about the words you need to remember. I will remind you the first parts, something we have discussed several times. This suffix emia means something in blood. So bacteremia is bacteria in blood. So whenever you have the suffix emia, it means something in blood. Okay. Next, urea. This should be pretty easy to understand. This is something in urine. Okay. First, azotemia. Now, what is azotemia? It is nitrogenous compounds. These are nitrogenous compounds in blood. These are usually breakdown products of proteins or other muscle activity that we get. The first one is called blood urea nitrogen. The other one is serum creatinine. And serum creatinine is a test we do to check for kidney function, to see if the kidneys are working properly. Because if serum creatinine increases, our kidneys are what removes creatinine. It's the only organ which removes the creatinine. So if you have blood creatinine high, that means the kidneys are failing. It's not doing its function properly. Next, oliguria. That means an urine output less than 400 milliliters per day. You need to remember this value, less than 400 milliliters per day. Next, uremia. That is urea in blood. This could be urea and creatinine. Next, pyuria. This is urine containing white blood cells or pus. Next, dysuria. If you remember from reproductive pathology, whenever you add the word dys, it means painful. So dysmenorrhea is painful menstruation. Similarly, dysuria is painful urination. Next, anuria. That whenever you put the word a, that means it's absent or it's very low. In this case, urine output is less than 100 milliliters per day. That means our kidneys are not producing urine. Finally, the opposite of it, polyuria. Our kidneys are supposed to produce around 1 to 2 liters of urine output per day. But in polyuria, you get urine output more than 3 liters per day. And I kept number 8 so that you can add substances. You get a lot of substances which end with the suffix urea, hematuria, etc. So you can add whenever you see something. Next, I will teach you to draw the glomerular structure, because you need this to understand pathology, because almost all the pathology lectures we are going to do today is about the glomerulus. Okay. First, I will draw the blood vessels. This is the afferent arteriole. Remember, afferent arteriole has a larger diameter than the efferent arteriole. Okay. So we have the arteries coming. This is the efferent arterioles. They go to become peritubular. They go on to become peritubular capillaries, which will drain into veins, finally into the renal vein, and then into the inferior vena cava. Okay. So these are the capillaries, and what I need you to know about these capillaries are, these have pores. These capillaries have pores. So what are the ground tissue between these capillaries? What is going to be present here? These are called mesangial cells. You can draw a cell or two. Also, you get, as usual, in these kind of places, you get the filler tissue that is called connective tissues. So what I'm drawing in orange is the connective tissues. So this is the connective tissues, and these two together form the mesengium. Okay. Next, we will draw the basement membrane. So the basement membrane is going to be between the capillary endothelium and the epithelium of the Bowman's capsule. So these epithelium have a special structure. These are called foot processes. So these epithelial cells have foot processes. These are called podocytes. These cells are called podocytes. And these structures are called foot processes. And this space, this gap. So it's better if you can draw these to touch these. I'll draw another diagram to show you from above what it looks like. These spaces, the space between the foot processes is called the filtration slits. It has a slit diameter of around 20 to 30 nanometers. Okay? And what I need you to know about the process in which substances filter is that there are two barriers. The first barrier is called the size barrier. This prevents large molecules such as red blood cells, platelets from entering the Bowman's capsule. Next, we have the charge barrier. Remember this is important. This is the main barrier that stops substances passing into the Bowman's capsule. What does that mean? So small proteins such as albumin, it's a small protein, the smallest actually in blood. It has enough size to pass through the filtration slits. It can pass through, but because of the negative charge on the barriers, remember, albumin is also negatively charged. They are going to repel each other, and the albumin cannot enter into the Bowman's capsule. Okay? These are the two barriers to which filtration occurs through. Okay? Next, I will draw an overview, like from above, how you see these structures. So we have the capillaries, and then we have the mesengium. These are mesangial cells. It's all in a groundwork of connective tissues. This is the connective tissues, and outer to the capillaries you get the basement membrane. These are the basement membranes, and you have these finger-like structures which come here. So label it like this. This is the vascular endothelium. This is the glomerular basement membrane, and this is the visceral epithelium, or these are podocytes. Okay. Next, we will talk about the diseases of the kidney, and the main part is we are going to do about diseases of the glomerulus. For our university, we need to know all of these, but we'll start it off with an introduction into what glomerulonephritis is. As you can read, it has the part itis. This means it's an inflammation. It's an inflammation of glomerulus. This is mostly due to immune complex depositions. This is the most common reason. And these immune complexes could be soluble ones, which can cause less damage compared to the insoluble ones. Okay. And when you take glomerulonephritis or most diseases, they are going to be either primary or secondary in origin. What does that mean? So what is a primary disease? It is a disease that originates in the kidney. So usually only the kidney is involved. But in the secondary disease, it could be due to another condition which affects the kidney. This is probably due to SLE, hypertension, and diabetes mellitus. These are the three common causes of glomerulonephritis as a secondary disease. And I will talk about how the pathogenesis occurs. So first, these immune complexes could be of the kidney origin. These are called in situ. Or it could be circulating immune complexes. And this is called type 3 hypersensitivity. This is called type 3 hypersensitivity. And how does that form? So let's take a blood vessel. And let's take a condition such as infective endocarditis, any disease condition in which our body will find some antigen somewhere in blood or anywhere. It will find an antigen, and our antibodies will come bind to it. Antibodies will come bind to these antigens, and this antibody antigen complex will travel to the kidney and deposit. Okay, they will travel to the glomerulus and get stuck. So this could be in 3 locations. It could be subendothelial, subepithelial, or it could be in the mesenterium. Okay. So let's take it here. It could be subendothelial, subepithelial, that is somewhere here, or it could be in the mesenterium that these deposit. And these gets trapped in the glomerulus. And to these antibody complexes, complements will come and bind. What are complements? These are proteins, defense proteins that circulate in our blood and are produced by the liver. And what happens then? The complements break down. This will start off an inflammatory reaction. So what happens during an inflammatory reaction? There's going to be white blood cells coming in, and there's also going to be fluid coming in. Also, we get repair happening. So what happens in repair? We get proliferation of these cells. Mesangial proliferation, endothelial proliferation, and parietal epithelial. I did not talk about the parietal epithelium, but it is basically the outermost. It will be outside. This is the parietal epithelium. Now I will talk about the type of microscopy we do to detect these immune complex depositions. The first type is called granular deposits. The other type is called linear deposits. So the way I draw these to represent it is, so let's assume this is how the normal structure looks like. And to this, if you have granular deposits, this is the granules which come and deposit. So you don't see the tubular structures. Instead, you see these granule deposits. You can see here. Next, we have linear deposits. These deposit along the tubules. So you can see the difference, granular deposits and the linear deposits. You can see this is the normal region. This is how it looks normally, and this is how it looks with linear deposits. It's along the lines of the tubules. Next, before we start nephritic syndrome, I want to talk about nephrotic syndrome. ROTIC. Okay, there's two. One is nephritic and nephrotic. This has to do with inflammation. This is not related to inflammation. So first, nephrotic syndrome. The three main stages, actually there's 4 changes we get. One is massive protein urea, that is proteins in urine which is greater than 3.5 grams per day. Our body produces around 10 to 12 grams of protein in a day, and from that around 3.5 grams are gone from the kidneys. Hypoalbuminemia. This is a state in which we get less than 30 grams per liter. And this is the most obvious sign, generalized edema. How does that happen? There's 2 types of edema. There's pitting edema and non-pitting. What is pitting edema? Pitting edema is edema in which, let's take the legs near the ankle. So you can press it and your finger mark will remain. It doesn't come back. Non-pitting edema is more common in situations such as cancers. In more dangerous situations, you get non-pitting edema. Pitting edema is what we get here. We push on the skin and the skin does not come back. In non-pitting edema, we push on it and it does not create a pit. We get hyperlipidemia and hypercoagulability, but that is not really essential here. So let me talk about what happens here. First, I will tell you how this happens. There is going to be damage to the kidney. There is going to be damage to the kidney with no inflammation. So in the glomerulus, there is going to be a defect. This is the basement membrane, and we have the blood vessels. So first situation is slight damage. I will use a plus here, that is to say slight damage. In this situation, the damage is slight enough that we get a state of selective proteinuria. Selective proteinuria. What does that mean? This is a state in which the smallest protein, that is albumin, will leak through. So that is why you get low albumin in blood. So these albumin molecules will leak through. Next, we have sub-nephrotic range proteinuria. Now I told you proteinuria must be more than 3.5 grams per day to be considered nephrotic syndrome. So the next stage is more damage to the kidney, but it is called sub-nephrotic range proteinuria. In this situation, not only albumin, the next smaller proteins such as globulins will also start leaving, but it is still not 3.5 grams per day of protein loss. So again we draw these structures, and this time we have to show the damage. So in this situation, we have albumin going in, we have other proteins such as globulins going through, etc. So this is sub-nephrotic range proteinuria, and if there is more damage, it is called nephrotic range proteinuria. What does this mean? This means it is in the range of nephrotic diagnosis. 3.5 grams per day of protein is lost. In this situation, get destroyed or damaged glomerulus. You have damaged blood vessels, everything is damaged. So all types of proteins. Remember, I only talked about proteins. I did not say cells or anything else. Okay? All types of proteins are going to leave into the glomerulus. And also remember this fact. We have cells here, the proximal convoluted tubule cells. They will take up some of these proteins and catabolize it. Not only that, lipids which can leak out will also be taken by these PCT cells, and they will undergo a fatty change. Okay. So this is what nephrotic range protein urea is. I will talk a little about how hyperlipidemia occurs. So now you can understand that there is going to be protein loss. So what does the liver do? Liver must compensate. And what it does is, it is going to increase the production of proteins such as albumin, globulins, and lipoproteins, even coagulative proteins. So what happens when there is lipoproteins produced? It is going to increase the levels of LDL in blood. That is not a good situation, because LDL is a bad fat, and it can lead to an increased risk of heart diseases. Coagulative proteins will also have a similar effect, because it is going to increase the risk of coagulation. Remember, this is a compensatory mechanism against the loss that has occurred. Normal production of proteins in the liver is around 10 to 12 grams per day. And we will learn several types of nephrotic syndrome. One is called Membranous Glomerulonephropathy. The other one is Proliferative Glomerulonephropathy and minimal change disease. These are the main things that we will talk about. So we'll start off with the first one. It's called Membranous Glomerulonephropathy. First, age of onset. Age is around 30 to 50 years. 30 to 50-year-olds. And this is a slow progressive glomerulonephropathy. We get diffuse thickening of the capillary walls. Remember, there is no inflammation in this situation. In nephrotic syndrome, there is no inflammation. So do we have symptoms like fever? No, we don't get those systemic fever symptoms, because in nephritic syndrome, it's the opposite. It's an inflammatory reaction. So how does the capillary walls thicken? We have the glomerular basement membrane. Here's the basement membrane. So to this membrane, we get the membrane attack complex. I hope you learned this. We have the MAC, that is the complex from C5b to C9, which will come and deposit. This is the MAC. Membrane attack complex. These will come and deposit. And this will cause the mesangial cells to produce proteases and oxidants. This will cause the mesangial cells and the epithelial cells to produce proteases and oxidants. So what happens then? This will go and damage the membrane. This is the clinical picture. I will show you how the membrane looks. So this is going to be the basement membrane, and we have the food processors. and these immune complexes will deposit subendothelially or in the subepithelium or in the mesenterium, whatever it is going to cause, okay, not the mesenterium, but wherever it deposits, it is going to cause an inflammatory reaction. Not an inflammatory reaction, it is going to cause the production of oxidants and proteases, which will destroy the membrane. Like this. And what happens then? There's going to be fibrous tissue which will deposit, and there will be sclerosis. I told you what sclerosis means. Sclerosis means hardening. Glomerular sclerosis. And we get hyalinization. Hyalin comes and deposits. That is how the thickening of the capillary walls occur. You can see these very thick walls, and these are called spike appearances. These are spikes which you get. These are the deposits that have occurred. You can see the thickened basement membranes. And these facts need to be known. These are highly leaky, and we get granular deposits. Here. Remember this could be a primary disease, that is more common, or it could be secondary. This is less common. So what is the cause of primary disease? Idiopathic. That means you don't know. What is the cause of secondary disease? Could be an infection by HBV, syphilis, or it could be a tumor, or it could be a autoimmune disease, and the inciting antigen is going to be DNA. So DNA is an endogenous antigen. It is part of our own body. Or it could be due to gold or mercury deposits or drugs. These are the common causes of membranous glomerulonephropathy due to secondary origin. Next, we will talk about membrano-proliferative glomerulonephritis. Remember, from the name you can tell a lot. The membrane, the proliferation of the membrane. What does that mean? There's going to be mesangial cells, matrix and glomerular basement membrane proliferation here. There's going to be proliferation of cells here. And this is more common in children and youth. And what is the cause of this? Idiopathic. When it comes to immune complex deposition, more commonly the cause is idiopathic, or it could be after a strep infection where you get pharyngitis, and around a month later you get symptoms in another organ. That could be in the heart or in the kidney or somewhere. That is due to autoimmune. It's similar to rheumatic heart disease. And in this situation, you get proliferation of mesangial cells, matrix and glomerular basement membrane. Mesangial cells, matrix and glomerular basement membrane. And in this situation, you get both nephrotic and nephritic syndrome together. So I will differentiate between the two types. First, we have membranous glomerulonephritis. And draw this with me. What I'm drawing here are the podocytes. And next, I'll draw the basement membrane. Yes. This is the basement membrane, and below that we have the podocyte foot processes. So we have the podocyte foot processes. First, I'll take the membranous glomerulonephritis. This will be Membrano Proliferative Glomerulonephritis. And in membranous glomerulonephritis, we get the deposits like this. They have this spike and dome appearance. There's going to be a dome produced over this. This is called the spike and dome appearance. And these are immune complexes which have deposited. Over that, the basement membrane will come and proliferate. That is what produces the dome. Next, we have membranoproliferative glomerulonephritis, and it has two types. Type 1 is subendothelial. So this is the blood vessels. These are the fenestrated blood vessels. This is the basement membrane, and these are the podocyte foot processes. So these are subendothelial deposits. This is type 1. And the other one is basement membrane, on the basement membrane itself. This is type 2. So we'll take type 1 and type 2. Type 1, membranoproliferative glomerulonephritis. It has subendothelial deposits of C3 and also IgG. C3 is the main one. Next, we have type 2, membranoproliferative glomerulonephritis. And this is also called dense deposit disease on glomerular basement membrane. And this condition has a poor prognosis. What does that mean? 40% will have end-stage renal disease. %30 will have renal insufficiency. And the remaining 30% will have persistent nephrotic syndrome with no renal failure. Persistent renal nephrotic syndrome with no renal failure. Okay, now I will go through this one more time. What happens in either membranous or proliferative glomerulonephritis? There's going to be damage to the basement membrane or to the filtration process. That is what is going to be shown here in these images. That will lead to a condition called as nephrotic syndrome, which will have different stages. If the damage is slight, we have selective proteinuria. The damage is not much, so that only the smallest protein will go through. Next, it will increase. The damage will keep increasing, so that bigger proteins such as globulins will also enter into the Bowman's capsule. That is called subnephrotic range proteinuria. And once it is more than the clinical diagnosis, that is 3.5 grams per day, it is called nephrotic range proteinuria. These are not hard words. This is just talking about the range in which we consider proteinuria. And I talked about the liver compensation. And the main thing is there's going to be pitting edema. Do you understand the flow? This region is about the damage to the membrane. This is about what happens afterwards. And finally, we have minimal change disease. What is minimal change disease? As the name says, there is going to be minimal changes. So this is a condition, a nephrotic syndrome in children. Nephrotic syndrome in children. This is the most common cause of nephrotic syndrome in children. Usually 2 to 3 year olds, and the most common cause of nephrotic syndrome. And what is important is glomeruli have normal appearance, and cause, it is idiopathic. There is reversible, uniform, diffuse loss of food processes. Reversible, uniform, diffuse loss of food processes. And we get selective proteinuria with good prognosis. What does that mean? These kids will not have long-term issues due to kidney disease. And the treatment for this is corticosteroids. What are corticosteroids? Corticosteroids are a group of drugs we give against inflammation. These are anti-inflammatory drugs. Here, I'll give some examples. One is called prednisolone. This is the inactive form. It converts to prednisone by our liver and makes it active. So these have the opposite effect against inflammation. These are anti-inflammatory drugs. That is it for nephrotic syndrome. Next, I'll talk about nephritic syndrome. So in this condition, there's going to be inflammation. There's going to be more damage. There's going to be a lot more damage, which will cause inflammation.